I see folks are trickling in. All right. Welcome. Good morning. Thank you for joining us. I'm Pam Connolly. I'm the Interim Director of Public Health for Santa Cruz County, and I will be moderating today's clinician resource call. As a reminder, the purpose of this meeting is to support Santa Cruz County clinicians in the evaluation and the clinical management of patients, and also to provide updates on public health trends. And we host this call monthly on the second Tuesday morning from 7:30 to 8:15. I'll also remind everyone to please submit your questions via the Q&A function rather than in the chat, and we will do our best to address all your questions before the end of the call. We also send out the slides and all of the resources to everyone who is attending the call. We usually do that within a couple of days. This morning we have a respiratory illness update from our health officer, Dr. Lisa Hernandez, and then we'll have a presentation on STIs by the Deputy Health Officer, Dr. Carissa Leclerc Cortez, followed by an update from the County Office of Education, Dr. Faris Sabah. Before we begin, I want to just mention that last week was National Public Health Week, for those of you who might have missed our big week. And just talk a little bit about how clinicians in public health have a really long history of working together. So we work together in a number of ways to improve health of our entire community here in Santa Cruz County by sharing data, insights. We work together to identify trends, control outbreaks, provide vaccines, and also to respond to emergencies. This call began during COVID-19, the beginning of the COVID-19 pandemic. Just showing how strong our partnership is. And National Public Health Week for public health professionals gives us a reason to pause and reflect on these partnerships that we really have to rely on to ensure that our community is stronger and healthier. So thank you for being our partners in caring for the health of our community. And now I'll hand it over to our health officer, Dr. Hernandez, to give us an overview of the latest respiratory illness trends. Take it away, Lisa.
Thank you so much, Pam. And I will just echo Pam's comments about the partnership between clinicians in our community and public health. As Pam mentioned, the pandemic was a very obvious and evident way that the partnership was needed and I would say successful. However, we know and depend on you, the clinicians in our community as frontline providers to help us continue to keep our communities safe every day. So the pandemic was a very obvious and evident example, but every day we partner with you and rely on your expertise to work together to keep our community safe. So I just wanted to mention that. And one example is for us to help provide you information regarding what we are seeing on a population level in terms of diseases or other conditions in our community. So this is a plug for you to let us know what you need to hear from us, and then a way for me to transition into the respiratory virus season. So if we could go to the next slide, very quick overview of what we saw in the last month. And I'll say this is that last month we ended the masking order that was in effect since early fall of 2025. And we do that because of the history of the trends that we see. And we also look at it, of course, real time to see how we're doing in terms of the viruses that we're using to decide whether we keep the masking order in place. And what you see here is that the RT, which shows how diseases are spreading in our community, is low for COVID at 0.9, which means COVID spread is decreasing. Our hospitalizations are low since mid-October, so that is extremely excellent. And our wastewater concentrations are very low as well. When we look at influenza, we're looking at the wastewater concentrations, and we are seeing a bit of increase with influenza A, but we're still considering that level to be low to moderate. And I was just looking at the levels just this morning on our website, and it is trending to still a low moderate, but low decreasing, I would say. So that is very favorable. And last but not least, RSV, where we're looking at the wastewater concentrations, and there's a little bit of a bump in RSV, but it's still considered in the low range. Next slide, please. And this is our traditional slide that looks at the reproductive number, our RT, and it shows what we've seen both for the since last year, May 2025, on the lower part of the screen, up until now. And again, you see that the levels are in the green area, even though they're closer to 1, it is still below 1. So we know that the transmission is low in our community. And then you see the blown up portion on the top part of the slide, and it shows you again for the last 3-ish months that we are still seeing that low. And I just want to remind you that we provide this information to you. However, you can look on our website at santacruzhealth.org and go onto the respiratory virus page where there's information about respiratory virus, our guidelines for different sectors of our community, and then there's a respiratory virus dashboards which give you the information in real time about RSV, influenza, and COVID. And that is my update, and I will give it back to you, Pam, or do I give it, or is Dr. LeClaire Cortez just taking it away?
I'm
Yeah,
happy to.
I'll go.
Oh, we're both
Yeah.
eager here. I'm happy to take it away if that's all right. Can we go to the next
Yeah,
slide?
yeah. I'll just remind folks to use the Q&A if they've got any questions.
Thanks, Pam. So for this month, we wanted to focus our clinician resource call on STIs to give an update of local trends that we're seeing in the county and to also focus on HIV and syphilis, particularly on screening and diagnosis for those diseases. We know that they can be a little more complex than other STIs, and there actually have been some updates to the guidelines probably since the last time we gave this presentation. Next slide, please. So first, looking at syphilis, these are our case counts each year within Santa Cruz County over the past 8 years. You can see that cases peaked in 2022, where we had 120 cases. That was at the time that we did have a known outbreak in the county, and thankfully have been decreasing since that time. In 2025, we had 39 cases. Something I want to note is that these case counts that you see here only represent primary, secondary, and early latent syphilis. So what's missing from that is late latent and also syphilis of unknown duration, which make up about 30% of cases. So just a note that these numbers that you see here are an undercount by about 30%. But overall, we have seen in recent years that there's been a disproportionate burden of syphilis diagnoses within Latino folks and folks within South County, who make up about 50% of the overall cases. In 2025, there was a notable increase in cases amongst females. So the split by sex historically has been significantly higher in males. And in the past year, it actually was 50-50 between male female. And the burden of cases is highest in the age group of 25 to 34. Next slide. So moving to HIV, you can see that new diagnoses of HIV have remained somewhat steady over the past 8 years, ranging between approximately 10 to 15 new diagnoses each year. You can see that in 2025, there was a slightly higher than expected number of cases. There were 18 new HIV diagnoses within 2025. Next slide. Breaking down HIV by demographics. So within the state of California overall, there's been a shift again to a higher burden of cases within Latino folks. So across the state, Latino people make up about 40% of the population, yet accounted for almost 60% of new HIV diagnoses. And we've seen trends that are really similar in Santa Cruz County. There's also been a notable uptick in HIV diagnoses amongst Latino, Latinx men who are 55 years or older. So this is a particular demographic that we've been paying attention to within our county. Next slide. And we wanted to just also mention Mpox as well, because I think this was something that we thought was potentially decreasing in a way that was going to go away. And unfortunately, we have seen a slight uptick in cases in the past year. So cases had downtrended to only one case in 2024. But in 2025, we did see three cases in the county and have seen a couple of cases this year so far in 2026. So just mentioning this so that it's something that you continue to keep on your differential. Next slide. So before we get into screening and diagnosis, we wanted to just provide a quick refresher on taking a sexual history in a way that's both thorough but also thoughtful. Of course, we know that this is important. Sexual health is an important part of overall health, and also asking the right questions helps us to determine which screening tests are appropriate. So everyone has their own process for this. For me, I like to give people the option to opt in or out of this conversation. So I say something like, is it okay if I ask you some questions about your sexual health, just so I can make sure that I'm offering all of the right options for your health? I try to give people control in the conversation and to share the reasons that are truthful but also simple why I'm asking these questions. So hopefully it seems a little bit less off-putting. So at least once a year, adults should be asked by their PCP if they've been sexually active in the past year. If they answer no, it can be helpful to ask if they've ever been sexually active. And again, if that answer is no, that's all you really need to ask. If any of the answers are yes, it's really important to ask more questions about who they have sex with and what body parts they use for sex. So the way that I like to ask this one is to explain in order to screen for sexually transmitted infections, we should test all of the different body parts that you use for sex. So, which of the following types of sex do you have? And I'll give you three options here: oral sex, penetrative sex in the vagina, and/or anal sex. If they answer yes to anal sex, it can be helpful to clarify receptive versus insertive to determine their risk level for different diseases. People probably don't know what those words mean, so people will usually understand asking top or bottom or both. From there, don't forget to ask whether they have sex with men, women, both, or other gender identities. I think there's a delicate balance of making sure to ask these important and normalizing questions and also tailoring your questions to your audience. So I used to work at UC Berkeley Student Health Services, and I asked this question very differently in that setting compared to where I work now at Watsonville Health Center, where I mostly care for older Latino folks. And I think that's okay as long as you put some thought into it and be sure to ask. Next slide. Next slide. So, jumping into syphilis screening recommendations, all sexually active people between the ages of 15 and 44 should be screened at least once in their lifetime and then have the test offered again annually. For folks of all ages, anytime that you're testing for other STIs, you should offer syphilis testing. Pregnant folks are a particularly high risk category, particularly given the risk of congenital syphilis. So the recommendations actually say that you should screen folks 3 times during their pregnancy. So number one, at confirmation of pregnancy or at the first prenatal encounter. Number two, early in the third trimester at around 28 weeks of gestation. And number three, at the time of delivery. If you work in an ED or a hospital-affiliated urgent care and someone presents who is pregnant without any syphilis results available, regardless of what they're there for, it's really important to offer syphilis testing to that person to hopefully get them a test result during their pregnancy. And then for folks who are in correctional facilities, all people who are between the ages of 15 and 44 years old should be screened at intake as soon as possible. Next slide. So syphilis testing can be a little wonky, so I'll do my best to keep it simple here. And this may partially be a refresher for you all, but I personally find the refresher is always helpful. There are two different types of serologic antibody tests that are required to confirm an initial syphilis diagnosis. So the first category is treponemal tests. That includes things you'll see TPPA, FTA-AB, or EIA. And then the other category is non-treponemal. Most commonly, you'll see RPR or alternatively VDRL. Best practice is to order a syphilis testing that has a built-in reflex confirmatory testing if that initial test is reactive. There are two screening algorithms that you can choose from for syphilis. They are both equally acceptable. I'll talk a little bit about the pros and cons of each, but in general, either one is totally fine. The traditional screening algorithm has been used more historically. Um, Not to favor Quest here, but I know that our county clinics use Quest and some of the other health systems here use Quest as well. So this may be an order that you recognize within Quest. It's RPR diagnostic, and then with reflex to titer and the T pallidum antibody. Alternatively, the reverse screening algorithm can also be used, and I'll talk about each of them. The order in Quest for this would be the syphilis antibody cascading reflex. Next slide. So jumping into the traditional screening algorithm, this one starts off screening with a non-treponemal test, most commonly RPR, or like I said, also VDRL. If that test is non-reactive, then it's unlikely that that person has syphilis and your testing is done. If that initial RPR is reactive, then it reflexes to a confirmatory non-treponemal, or sorry, to a treponemal test that's confirmatory, and that's often a TPPA. If both are reactive, then you are able to make a diagnosis of syphilis. Notably, this doesn't distinguish between a current or prior infection, so you'll have to do a little bit more investigating with that. Hopefully, there are lab results available that you can compare to, and hopefully, treatment records as well that you could seek out from the county public health department. The traditional screening algorithm has slightly lower sensitivity. A couple instances that might be missed are early primary syphilis or late untreated syphilis. So either it's so early that they have not yet created enough non-treponemal antibodies to be reactive, or they've had it for so long and it's been untreated that they actually are no longer reactive. So those are the two instances that could potentially be missed if you're using the RPR as your primary screener. Next slide. So the reverse screening algorithm starts off with the treponemal test. That's often an EIA or a CIA. Again, if that's non-reactive, then that person, you can say, doesn't have syphilis. If the initial test is reactive, then it will reflect to a confirmatory non-treponemal test with an RPR or VDRL. If both are reactive, then again, you can make a diagnosis of syphilis and you'll just have to investigate whether that's a current infection or a prior infection. If the results are discordant, so say your initial test was positive, but then the RPR is non-reactive, you have discordant test results. And from there, you actually can't say you don't have syphilis. It then goes on to an additional treponemal test using a TPPA in order to clarify that discordance. And so if the TPPA is non-reactive, you have enough evidence to say syphilis is not likely. However, if that's reactive, then you consider it as if that person does have syphilis and potentially were not yet reactive to the RPR. This reverse screening algorithm does have higher sensitivity, and unfortunately also comes with an increased rate of false positives. The truth of choosing between these two algorithms is it often is decided at a laboratory level, depending on whether they run a lot of these tests or not, depends on what they offer, or potentially also a clinic workflow level. So that may determine which one you choose. If you work in a setting like myself where you have both of these options available, then I work at Watsonville Health Center. I know there's a pretty high pretest probability of folks having syphilis. And so for that reason, I'd prefer to have a test with higher sensitivity. So I slightly prefer the reverse screening algorithm. Next slide. So lastly, we really wanted to mention the potential syphilis complications of neurosyphilis, ocular syphilis, and otosyphilis. So every single person that gets diagnosed with syphilis needs to be specifically screened for symptoms consistent with neurosyphilis. So this might be neurological symptoms. So most commonly, people will present with meningeal signs. So headache will be most common. Later on, you might see motor or sensory changes. People also should specifically be asked about vision changes, decreased hearing, tinnitus, balance problems. And then if someone has late complications of neurosyphilis, it actually can lead to vascular problems and ultimately stroke. This can happen at any stage of infection, including early syphilis. So if someone has neurologic symptoms, they need to get a lumbar puncture and CSF studies to evaluate this. If someone has ocular or otic symptoms, you may still want to order a lumbar puncture, but know that a negative lumbar puncture doesn't rule out ocular or otosyphilis. They actually need a thorough evaluation by ophtho or ENT. Next slide. So moving into HIV screening and testing. Next slide. So starting off with the guidelines on who to screen. So for folks who are adolescents and adults between the ages of 13 and 64, they should be screened for HIV at least once in their lifetime. For those who have an increased risk of infection, you'll want to screen them at higher intervals, and I'll talk about that on the next slide. Anytime that folks are seeking treatment for an STI, you should routinely screen them for HIV infection every time that they come in with this new complaint. For pregnant folks, again, very high risk, they should be screened for HIV infection as early as possible, including if it hasn't happened thus far, folks who are in labor and delivery who don't have an HIV status that's known. Consider a repeat screening for HIV during the third trimester if it was ordered earlier in the pregnancy and that person has risk factors. And then if folks are initiating TB treatment, they need to be routinely screened for HIV, just given the commonality of co-infection and also the potential for much more severe presentation of TB. Next slide. So folks who should be offered additional screening for HIV, in these populations, you should offer HIV screening at least on an annual basis. So sexually active men who have sex with men, people who have a sex partner who is HIV positive, people who inject drugs, people engaging in transactional sex, and if people have had one or more new sex partners in the past year whose HIV status is unknown. Those folks should qualify for additional screening at a shorter interval. Next slide. So again, the actual nitty-gritty of the laboratory diagnosis of HIV can be a little bit complicated. I'm going to talk you through it just so you understand the reasoning, but the short of this is order a reflexive panel so you have the right tests already built into it. And so when you order, usually it'll be the fourth gen that you'll want to use the reflexive panel, and it starts off with what's called a combination immunoassay. So this includes testing for P24 antigen, which can be one of the earliest markers that can react as early as 2 to 4 weeks. It also checks for an HIV-1 antibody and an HIV-2 antibody. Notably, this test doesn't discriminate of which one is reactive. It'll just say yes or no, reactive or no. If that person is negative, then you can say, you have a negative test for HIV. If this is positive, then it will reflex to a differentiation immunoassay, which can detect HIV-1 versus HIV-2. So say if that is reactive for HIV-1, then that would be a diagnosis made of HIV type 1. If the differentiation assay is negative or indeterminate, then it will reflex to a NAT, which is a PCR. And that can actually help to detect an acute infection if antibodies have not been formed yet. If you suspect that someone has an acute HIV infection or has a high-risk exposure within the last 2 to 4 weeks, it's also important to check an HIV RNA, which can be, again, one of those early markers that will react positive. Next slide. So we wanted to touch on PrEP because there are some exciting changes and also some updates in guidelines of who you should be offering it to. Next slide. So who should be considered for HIV PrEP, pre-exposure prophylaxis? folks who have an HIV positive sex partner, even if that partner has an undetectable viral load. For men who have sex with men and transgender women who have sex with men, if in the past 6 months they've had either condomless anal sex with multiple or anonymous partners, or if they have a partner that has risk factors. And then alternatively, if they've had an STI diagnosis in the past 6 months, they could potentially be a good candidate. And then again, this is a newly added category for heterosexual cisgender women who have sex with men, and those men have risk factors. So all of these folks are great candidates to potentially be offered HIV PrEP. Next slide. I'm not going to talk about all of the different options for PrEP, but one thing that we wanted to just mention for folks who have not yet come across this, recently the FDA has approved a long-acting injectable PrEP. Lenacapavir is the name, or you'll see Yetsugo is the brand name. This is an injection that's given every 6 months for folks who are HIV negative, and it's more than 99% effective at preventing HIV transmission via sex in folks of all genders. And thankfully, it is covered by Medi-Cal without a prior auth. So certainly something to consider for certain patients within those higher risk categories. Next slide. And of course, I can't give a presentation without mentioning reporting, so we wanted to just give some reminders here. Next slide. So there are distinct pathways depending on whether you're reporting HIV or other non-HIV diseases. So for non-HIV diseases, you hopefully remember there are two different numbers that you can call. There's one for business hours, weekdays 8 to 5. If you're outside of business hours or if you're calling on a holiday, there's a separate number that will send you to dispatch and then connect you to one of the health officers. Alternatively, you can fax the CMR or you can submit it via CalReady, the provider portal. You can send an email, and then there's a link to our website on here where we try to keep up to date on outbreaks or other information that you might need for resources. Next slide. And then HIV is slightly different. So there are two options for HIV. The first option is reporting by fax or mail, and it's slightly different depending on the age of the person. So if it is someone being diagnosed who's 13 years or older at the time of diagnosis, then you'll use the adult confidential case report. If people are 13 or under 13 years, then you'll want to use the pediatric case report. Those can be submitted by fax or can be mailed to Santa Cruz Health Services Agency. And then the second option, which I think is probably slightly preferable, you can actually report by phone. So you can call one of our specific numbers, and we actually have staff that can help you to complete the report over the phone. And that way it can be a little bit quicker in getting people connected to our supportive services. Next slide. All right, and I will pass it back. Thank you so much.
Thank you, Carissa. There are a couple of questions in the Q&A, that I don't think we've answered yet. The first one is from Dr. Laval for Latinx men who have HIV. How are we defining men? And did the data include our trans population where trans women are at a higher than average risk?
These are great questions. If it's okay, just for the sake of time and for me to be able to be thorough, is it okay if I actually type the answer in the response? And then if we have time at the end, then we can actually share them verbally.
Sounds good.
Sweet, thanks.
I'll pass over to Dr. Ferris Sabah, our County Superintendent, for a schools update.
Hi, good morning. Thanks so much for the opportunity to provide a brief school health update. Next slide, please. As you know, schools remain critical hubs for both learning and wellness for students and families. However, we are facing a lot of reductions in funding due to declining enrollment, and this is impacting key services, including health and mental health supports in schools. And it continues to reinforce the need for strong partnerships with our clinical providers. This comes at a time when many young people continue to face mental health challenges. While we're seeing encouraging signs of improvement since the pandemic, including a reduced percentage of students reporting symptoms of anxiety, depression, and suicidal ideation, we know how important ongoing support is. In that context, it's encouraging that the Santa Cruz County Behavioral Health has opened a 24/7 crisis stabilization unit at the Hope Forward Esperanza Adelante Youth Crisis Center at Soquel Avenue to support youth in crisis. I did want to share that proposed federal education cuts are being, well, the cuts are being proposed for the 2026 budget, which are going to be creating additional challenges for us, especially for our K-12 and our higher education partners. And we believe this is going to have potential downstream impacts on student support systems. Next slide, please. So we track all the different ways that the federal initiatives and efforts are impacting our community. Everything from immigration action to discretionary funding cuts and court decisions that have had a deep effect on a variety of different ways that schools are able to serve our community and our ability to advocate for many in our community. And especially our most vulnerable communities, our LGBTQ community and our immigrant community. And I think it's important to continue to focus on these because they have such deep effects on the services we're able to offer. Next slide, please. There is recent legislation that has affected a broad coordinated effort to improve health, safety, and student well-being. There's several bills that are now in effect related to public health and nutrition, including banning ultra-processed foods, things like supporting for families and vulnerable populations, adding diapers and wipes to emergency food supplies, and broadening access to mental health treatment through court. New laws aim to support student well-being and academic success by requiring suicide prevention resources and student IDs, limiting smartphone use during the school day, and improving literacy and resources and training. All of these are really part of a concerted effort, which is maybe somewhat different than the federal effort at this time, to ensure that we are emphasizing prevention, early intervention, and equitable access for children, families, and communities. Thanks so much. And I did want to give a shout out to our school nurses. I believe it's May 6th is going to be the day of the school nurse, and just want to uplift them and thank them for all their amazing work on behalf of students every day. Thanks so much. Next slide, please.
Thanks, Dr. Sabah. All right, so that brings us to the end of our content and our presentations. We're now turning it over to your questions, so please continue sending in your questions. If there are any questions we can answer live, we can do that as well. I'm not seeing any additional. I see we have one question about prep still in our Q&A. I don't know, Chris, are you working on the last question
I
in
am
the
working on the last one.
Q&A?
I actually have to look at the recommendations. I don't think that is included in the folks who are recommended, but I am double checking on that, and we can certainly include it in the meeting notes. I think that's a great question. I believe in the studies on lenacapavir, it was specifically focused on risk via sexual transmission, but I would have to look to see. I imagine there would be some type of effect, but I don't know if that would be necessarily covered for that type of risk factor. So I'll totally check and I will get back to you.
Sounds good, thank you. So we'll include that in the question in the materials when we send out materials, and we'll have that question answered. And it doesn't look like we have any other questions in our Q&A to answer this morning. So I'll just say thank you all for attending. And again, we'll send out all the resources shared today, including the slides and the recording. And it takes us a couple of days to get that together. And then as a reminder, our next call will be on the 12th of May from 7:30 to 8:15. And please do forward the information for calling into call to any of your colleagues you think that the content might be meaningful to. And as Dr. Hernandez mentioned at the beginning of the call, if you have any suggestions, of course, let us know, and we'll do our best to incorporate that in future presentations. Thank you so much for being here. And again, thanks for your partnership and caring for our community.